Hi and welcome back to another video of Medic Notes. This video is on trigeminal neuralgia. Trigeminal neuralgia is a condition that causes severe, sudden, and stabbing pain along the path of the trigeminal nerve, which is responsible for sensation in the face. The pain is usually triggered by simple activities like chewing, speaking, brushing your teeth, or even a light breeze on the face. The pain is often described as sharp, electric shock-like, and can occur in episodes, sometimes lasting for seconds or minutes. The trigeminal nerve has three branches. The ophthalmic branch innervates the forehead, eyes, and scalp. The maxillary branch innervates the cheeks, upper lip, and upper jaw. And the mandibular branch innervates the lower jaw, lower lip, and chin. Trigeminal neuralgia typically affects one side of the face, and it can range from mild discomfort to excruciating pain. The primary mechanism underlying trigeminal neuralgia in most cases is vascular compression of the nerve at the root entry zone in the brainstem. This compression leads to demyelination of the trigeminal nerve, causing abnormal neuronal firing, which results in pain. This mechanism is most commonly associated with an artery or vein, often the superior cerebellar artery, compressing the nerve root. Other less common causes of TN include multiple sclerosis, where demyelination occurs at the nerve root due to immune-mediated damage to the myelin sheath. Tumors or vascular malformations that can compress the nerve. And trauma, such as following a stroke or facial injury. For clinical presentation, pain characteristics. Trigeminal neuralgia is marked by paroxysms of intense, sharp, stabbing pain often described as an electric shock, lasting for seconds to minutes, usually unilateral. Triggers. Pain can be triggered by innocuous stimuli such as light touch, chewing, speaking, or brushing teeth. These triggers are due to abnormal nerve excitability caused by compression or demyelination. Pain typically affects the V2 maxillary and V3 mandibular branches, though it may involve the ophthalmic branch in a minority of cases. Pain distribution. Pain follows the sensory distribution of the affected branch. In classical TN, the pain is unilateral, although bilateral involvement may occur in 2 to 5% of cases, particularly in the context of multiple sclerosis. Pain frequency and duration. The frequency of episodes can vary, with periods of complete remission and recurrence. The pain is episodic, but it may be refractory in chronic cases, leading to constant, severe discomfort. For differential diagnosis, secondary causes include multiple sclerosis or tumors. In multiple sclerosis, trigeminal neuralgia is often bilateral and can be associated with other neurological signs like sensory loss, motor deficits, or cerebellar symptoms. Glossopharyngeal neuralgia. Pain localized to the throat, ear, or base of the tongue, triggered by swallowing or speaking, often confused with TN. Temporomandibular joint disorders. Referred pain from TMJ dysfunction can mimic TN. Sinusitis, dental problems, or trigeminal neuropathies. These conditions should be considered in the differential diagnosis. Diagnostic approach. Clinical diagnosis. The diagnosis is primarily clinical based on the history and characteristic episodic, sharp, stabbing pain in the trigeminal nerve distribution. The absence of other neurological signs or causes, such as tumor or multiple sclerosis, strengthens the diagnosis of primary TN. Neuroimaging. MRI with gadolinium is the imaging modality of choice to evaluate for secondary causes. It helps identify vascular compression at the nerve root or any other structural abnormality. In cases of bilateral TN, MS should be strongly considered, and an MRI will often show demyelinating plaques. MRA can help identify vascular compression of the trigeminal nerve. Electrophysiology. Trigeminal reflex testing can sometimes be used to assess nerve function but is not typically necessary for diagnosis in classical TN. Treatment can be pharmacological or surgical. For pharmacological treatment, first-line medication will be carbamazepine. It is the most commonly used anticonvulsant and has been shown to be effective in controlling pain. It acts by stabilizing hyperactive neurons. Other meds include oxcarbazepine, gabapentin, baclofen, or lamotrigine. Surgical options are considered for patients who fail to respond to pharmacological management or who experience intolerable side effects. Surgeries include microvascular decompression, a procedure where the offending blood vessel, commonly the superior cerebellar artery, is decompressed from the trigeminal nerve. And gamma knife radiosurgery, a non-invasive procedure that targets the trigeminal nerve with focused radiation. Percutaneous procedures such as radiofrequency rhizotomy, glycerol injection, and balloon compression can provide relief by selectively damaging the trigeminal nerve fibers. In cases of secondary TN, the management of the underlying cause is essential. In these patients, medications like carbamazepine may still be used, but MS-related TN may require careful monitoring due to the risk of multiple neurological sequelae. For its prognosis, the long-term prognosis of TN varies. In patients who respond well to medical treatment, the pain may be controlled for many years. However, TN is often a progressive condition, with increasing frequency and severity of attacks over time in some individuals. Surgery provides long-term relief in many cases but is not without risks, including complications such as hearing loss or facial numbness. As a summary, trigeminal neuralgia is a debilitating condition with a characteristic clinical presentation of sharp, unilateral facial pain triggered by mild stimuli. Early recognition and appropriate management with anticonvulsants, surgical decompression, or percutaneous procedures can provide significant symptom relief. For secondary TN, it is essential to address the underlying cause, such as multiple sclerosis or tumors. That's all for this video. Thank you.